welcome back to Coursera Nursing. My name is Will Kirkpatrick. I'm a nursing educator inside the Coursera Nursing membership. And today we're going to go over pancreatitis. Pancreatitis, we're going to go over the signs and symptoms, the pathophysiology, the risk factors, complications, and of course the nursing management. If you're wanting to write notes with this course, we have a free pathophysiology concept map that is available on CorseraNursing.com. Alright, so let's first start with the pathophysiology of pancreatitis. So pancreatitis is simply just the inflammation of the pancreas. Now, of course, we can have acute pancreatitis, a sudden onset of it, or a chronic pancreatitis. Let's first talk about the pathophysiology of acute pancreatitis. A common pathway that causes acute pancreatitis is related to a bile duct obstruction. So when that happens, bile backs up and gets into the pancreatic pathways and activates pancreatic enzymes. So those pancreatic enzymes that you always hear about is protease, lipase, and amylase. Protease is the pancreatic enzyme that breaks down protein. Lipase is the pancreatic enzyme that breaks down fats. And amylase is the pancreatic enzyme that breaks down carbohydrates. So how this should work is the pancreas releases these enzymes into the duodenum to begin digestion and absorption of those nutrients. But if there's something such as a bile duct obstruction that causes bile to back up into the actual pancreas, it activates those enzymes too early, and that begins the breakdown of tissue inside the pancreas. Of course, when that happens, it'll cause inflammation, hence pancreatitis. So you can really think that pancreatitis is literally the pancreas getting eaten by its own enzymes from the inside out. And then there's chronic pancreatitis, which is more of a progressive disease that causes inflammation in the pancreas, and it causes structural changes due to other factors such as diet and alcohol that can eventually cause obstructions in the pancreatic ducts and the bile duct. So what are the common risk factors that can cause pancreatitis? Well, one that NCLEX and the nursing exams love to ask about is alcohol abuse. Alcohol abuse can cause pancreatitis in a number of ways, but one of those ways is early activation, once again, of those pancreatic enzymes. Other risk factors that they like to highlight on for your nursing exams in NCLEX is obesity, high triglycerides, smoking, corticosteroids, and don't forget these other two guys, is pancreatic masses or cancer in those ducts causing obstruction, preventing those enzymes from getting to the duodenum, and they get activated in the pancreas once again, and the biliary obstruction, so cholecystitis. So make sure you remember those top three that I gave you: alcohol abuse, cholecystitis, and cancer, so masses in the ducts themselves. Hey guys, it's Will Kirkpatrick, nursing educator inside Coursera. I wanted to let you guys know that I will help you with anything you need at any time if you just send me a text at 940-218-4062, 940-218-4062. Let's get back to the video. Now, let's get right into the signs and symptoms because it directly relates to the pathophysiology itself. There are two signs that are significantly asked about on the NCLEX and the nursing exam, and that is Cullen's sign and Turner's sign. So Cullen's sign is bruising around the umbilicus, and then Turner's sign is bruising around the flank. The way I like to remember it is that you have to turn to see your flank, so that's your Turner's sign. And the reason why we see this is that the inflammation in our abdomen surrounding the pancreas can cause bruising surrounding that tissue. So you're going to see that on your abdomen or your flank. Other signs and symptoms is hypoactive bowel sounds. Why? Well, because we don't have those pancreatic enzymes getting released into that small intestine to begin digestion and absorption. So there's a decreased activity in the bowel itself. So that's why we have hypoactive bowel sounds. And of course, you can expect that this patient would be in a lot of pain. So specifically the epigastric region, so above the umbilicus, is what you would typically see with a pancreatitis patient, and that may radiate to that left shoulder. And since we do have a lack of absorption now, we can expect weight loss and steatorrhea. So that is fatty stool, because we don't have the lipase, for example, to begin the breakdown of fats in our stool. So because of that, it's just going to be excreted out with our bowel movements. And because of potential malabsorption and fluid loss through our bowel movements, then we're going to have possibly hypotension and tachycardia due to the fluid deficit. Now, what are these complications we need to worry about with pancreatitis? So if you know about the pancreas, it has an endocrine function and an exocrine function. So everything we just talked about so far is the exocrine function, so the enzymes that leave the pancreas into our GI system. What about the endocrine system? So our pancreas, of course, has alpha cells, beta cells, and delta cells. The beta cells release what? Insulin. So when we have inflammation at the pancreas, it's going to have a decreased production of insulin. So in result, these patients are at risk for hyperglycemia. So whether it's acute or chronic, acute being more of the profound hyperglycemia that could result, more chronic being patients with diabetes. Another one you could expect with the complications is a paralytic ileus. Once again, you don't have enzymes getting released into that small intestine. It's going to decrease the activity in the bowel, and that includes possibly peristalsis. So you could have paralytic ileiuses result from pancreatitis. And then lastly, you want to write this one down. It could also cause atelectasis. Because of the inflammation that's directly below the diaphragm, where our pancreas is at, it could cause atelectasis, so the collapse of our actual alveoli, so you could have a patient with acute respiratory distress related to the pancreatitis as well. All right, now we're on diagnostic. So what diagnostic results could point to pancreatitis? So if you think about these pancreatic enzymes, once again, these are the true cause of the disorder or disease in general. So we have high amylase and lipase level. These are the most specific blood tests that we can do related to pancreatitis. And then, of course, we can look at the bilirubin if it's related to cholecystitis, and of course the liver enzymes as well. So overall, if we have a high amylase, lipase, bilirubin, or liver enzymes, then it could possibly point to pancreatitis. All right, guys, we're on the last section, management. So what is the management of pancreatitis? First of all, we need to make sure we are not doing anything to stimulate pancreatic enzyme release. Because what is the whole problem when we talk about the pathophysiology? It's early activation of pancreatic enzymes. So we don't want to stimulate the bowel to tell the pancreas to release more enzymes because it's essentially telling it to activate in the pancreas because it can't go anywhere. So the first intervention is MPO. So nothing by mouth, nothing to stimulate the bowel. We need to make sure we're not putting anything in the body that could stimulate. So carbohydrates, proteins, or fats could stimulate those pancreatic enzymes to be released. So we need to make sure that they're MPO. Of course, it really depends on the underlying cause. So whether it's cholecystitis, or if it's just alcohol abuse, we need to make sure that we're treating the underlying cause. Once that is resolved, we can gradually introduce intake again. But when we introduce this food again, we want to make sure we're doing a low-fat and low-protein diet. And since these patients aren't getting the correct absorption or pancreatic enzymes to absorb, they're also at risk for low-fat soluble vitamins such as A, D, E, and K. So those vitamins could be supplemented during this time as well. So what about medications? What medications could we prescribe for these types of patients? One of those medications is octreotide. Octreotide suppresses the release of pancreatic enzymes, or at least reduces the response of pancreatic enzymes to be released. And of course, the rest, if there's hyperglycemia, we would of course prescribe insulin to help counteract that. These patients, once again, are at risk for fluid deficit, so we want to go ahead and supply IV fluids. And these patients are likely having pain, so pain medication, and they're at risk for lung issues, so probably oxygen supplementation as well. So what are those specific nursing interventions that you'll be questioned about on the nursing exams and NCLEX? Well, one of those is knowing how to correctly treat the pain management. But what are those non-pharmacological interventions we could do? Well, we can promote side lying with the knees flexed. If it is appropriate for the patient, according to the nursing exams and the NCLEX, this is a proper intervention to do. And of course, we want to do strict eyes and nose. We want to monitor for respiratory distress and monitor for hyperglycemia.